Hello everybody. Over the next few minutes we will discuss how you balance the harm and the risks of the MRI pathway. Here are my disclosures. We know that prostate cancer diagnosis is a risk-based pathway where there are two risk assessments that are made. Initially, the patient is assessed for the likelihood of clinically significant cancers based on clinical assessments with PSA, DRE, and family history, for example. And then there's a second risk assessment that's made after the MRI, and these are outlined here in the blue. Nevertheless, you must realize that any risk-based assessment will have benefits and will have harm. So what are these benefits? Well, the benefits clearly arise from the true positives and the true negative results. So from the true negative results, you get reduced diagnoses of indolent cancers and fewer men undergoing a biopsy. And from the true positives, you get a more accurate targeted biopsy and better grading of the tumor. And you, at the same time, you have a non-inferiority in the detection of clinically significant disease in biopsy-naive men. So these true results, true positives and true negatives, give you benefits, which of course have to be balanced with the harm that arises from the false results. The false results arise from false negatives and false positives, and clearly we need to think about the variability of the PPV and the NPV when trying to assess the harm. So if you look at the harm of false negatives in 10 UK centres, for example, you can see the negative predictive value is 88%. And there's very little variation between centres. So what we're saying is we miss between 5 and 12% of cancers, but this is consistent. On the other hand, if you look on the right-hand side, you can see the false positive harms. The false positive harms, here displayed in 25 mostly US centers, shows you that if you do a targeted biopsy, that there is an inconsistent yield of the prostate cancer. And you can see that the yields vary from 25% to 75%, averaging at about 50%. In other words, we're saying there's an inconsistent target biopsy yields of clinically significant cancer. So you can see how the variability in the false positives is much greater than the variability in the false negatives. So what we want to do is to reduce false positives while maintaining the benefit from the true negatives. Remember, the main benefits come from true negatives. In other words, reduced biopsies and reduced detections of indolent cancers. And we are trying to reduce false positive harms. In other words, the harms from unnecessary biopsies, overdiagnosis, and active surveillance. So how do we go about doing that? Let's assume that we have a perfect examination, something like this. Okay, so you've got an optimized protocol. You have high image quality, you have radiological expertise, you have biopsy expertise, and everybody's working as a team. So this is the ideal situation. So if you get perfect images, then how do you mitigate for false negative harm? Remember, that's not the greater harm, there's the false positive harms are greater. But false negative harms, we said, occurs between 5 and 12%. It's low variability, and remember the harm is missing important cancers and delaying treatment. So we can do this by improving the clinical risk stratification, for example, looking at family history, the racial history, PSA-density, SNPs, polygenic risk scores, and of course we can use PSA-density in PI-RADS 1 and 2 cases when trying to make a biopsy decision, and we can always use safety net monitoring. So these are mitigations for the false negative harms. Now, for the more important false positive arms, we said, remember, this is between 30 and 50% and is highly variable. So we need to do a number of strategies, and this is what I'm going to concentrate on in the next few minutes. So one is to account for the patient's tolerance to false alarms, false positives, false alarms. So we know that the EAU accepts a miss rate of 10%. So if there is a more than 10% chance of clinically significant disease, then the EAU guidelines say that these patients should get a biopsy. Now, of course, that 10% is not set in stone. Remember, there are going to be patients who are biopsy averse and patients who are cancer averse. Let's take the example of a cancer averse patient. Here, this patient is scared to death of a cancer. For example, the PSA keeps rising. There's been a prior negative biopsy, for example. This patient is really worried about a cancer, so the threshold for biopsy would be lower, say 5%. There will be other people who are biopsy averse. Young men who have an isolated PSA. These patients do not want overdiagnosis, and they're more concerned about the biopsy, and they're more tolerant of they're less tolerant of a false alarm. So you may want to increase the threshold before you biopsy in these men. So you can see there's a spectrum, as you can see in the scale on the right hand side, but you certainly need to take that into account. The other thing you can do is improve the reading of MRI scans to eliminate false positives. So is there a difference between a false positive lesion and a true positive lesion in terms of the MRI assessment? The answer is there is, and this paper shows it. So essentially, a significant prostate cancer patient usually has higher PSA density, has single or multiple lesions. Lesions tend to be quite large. There is a very discrete lesion that you can visualize with more restricted diffusion, whereas insignificant cancers or false alarms tend to have lower PSA density, 1 or 2 lesions. The overall conspicuity of these lesions is less. So there is a visual difference between the two. The other thing you can do is you can adjust the PSA, the suspicion score, for what is not a significant lesion before you make a biopsy decision. So for example, in secondary care, this is what we tend to do. We say everything from 3 to 5 is a significant lesion, and anything 1 and 2 is an insignificant negative scan. So what stops us doing this? We can merely change the threshold at which we decide what is positive and what is negative. What's the downside? The downside is that we'll get more false negatives just by shifting the positivity negativity threshold from 2 to 3. So what sort of patient would be suitable for PI-RADS 3, 4 and 5 as a positive case? Well, these are people who are in secondary care, where there is a higher pretest probability that there is a clinically significant cancer. So in urological clinics, generally speaking, the pretest probability of clinically significant disease is anywhere between 30 and 50%. So in these men, you have to apply PSA density for PI-RADS 2 and 3 cases, because you're going to biopsy all PI-RADS 3 cases. Some centers don't biopsy PI-RADS 3 cases. Only do so if the PSA density is high. So 3 to 5 is what you would use in secondary care. PI-RADS 4 and 5 is more suitable for primary screening. Why? Because there is a lower pretest probability of clinically significant disease, usually about 4%. So in these people, you have to adjust the PSA density. You have to use PSA density to adjust for PI-RADS 1, 2, and 3 so that you don't underdiagnose clinically significant disease. So you can see how you're using different thresholds for different clinical prevalences. Next, we must talk about how you biopsy based on the patient's clinical risk, including their PSA density. So many of you will have seen this table that appeared in the latest guidelines of the EAU. I've just deconstructed this table into this graph. Essentially at the top you can see the PI-RADS score, and as the PI-RADS score increases there's a greater likelihood of clinically significant disease, and on the top right you can see PSA density, and as the PSA density increases, so you can see that the incidence of prostate cancer increases, as you might imagine. And of course you can combine the two into the composite graph at the bottom. Now let's compare a person who is going to get a biopsy regardless of the PSA density and the PI-RADS score. If you did that, you can see that nobody avoids a biopsy. You can see that the false positive rate, the last column, is 63%, and you would detect 809 cancers, but you would not be able to benefit from the true negative because everybody gets a biopsy. Now, what happens if you biopsy only PI-RADS 3, 4, and 5? You'll see that 38% of men are able to avoid a biopsy. You would miss 6% of cancers, and you can see that the false positive rate decreases to 45%. So if you just don't biopsy PI-RADS 1 and 2, these are the benefits that you would get. What about if you said, okay, I'm going to biopsy PI-RADS 3 with a high PSA density and all 4s and all 5s? What would be the benefit? You can see more people avoid a biopsy, 45%. You can see that the false positive rate decreases from 45% to 39%. Of course, you will miss cancers. And these cancers, you can see the miss rate of cancers goes up from 6% to 8%. So in other words, there's a small penalty in terms of a false negative if you were to biopsy in this manner. Now, remember what we said. We said that the EAU threshold is 10%. So what happens if you biopsy negative cases with a higher PSA density, PI-RADS 3 cases with a high PSA density, and all 4s and 5s? How does that compare? Well, if you compare with PI-RADS 3 to 5, which is what we're doing at the moment, you can see that the number of biopsies avoided is exactly the same, 38%. You can see that the number of cancers that you miss is exactly the same, 6%, 5%, so no difference. But look at what happens at the false positivity rate. The false positivity rate falls from 45% to 39%. So you can see how individualizing the risk according to the PI-RADS score using the PSA density enables you to lower the total number of false positives that you get. Another way of reducing the number of false positives is to optimize the biopsy pathway after the MRI. What do I mean by that? To understand this, let's compare the North American way of doing a biopsy and the European way of doing a biopsy. In North America, all men are destined for biopsy and will have an MRI. If an MRI is positive, then what happens is you get additional targeting biopsies. So everybody gets a systematic biopsy, and those men with a positive MRI get an additional targeting biopsy. In Europe, traditionally, if you had a negative MRI, there was no biopsy, and if you were positive for an MRI, PI-RADS 3, 4, and 5, then you've got both a targeted and a systematic biopsy. So you can see there is in fact a difference. Recently, the European approach has changed to the risk-based pathway. In other words, if you have a negative MRI and you are at low risk, then you do not get a biopsy. If you're negative and you have a higher risk, then you do get a biopsy. Ditto with the PI-RADS 3. And of course, if you have PI-RADS 4 or 5, then of course you will get a targeted plus systematic biopsy. So if you look at the latest guidelines from Europe, you can see that when an MRI is negative and clinical suspicion is low, and you can see they've mentioned the PSA-density, omit the biopsy based on shared decision making. So you can see this shift in Europe towards a risk-based pathway. So let's just look at the outcomes of the North American method and the European method in terms of benefits and harm. So if you look at the North American method, the benefit is that you get more detection of clinically significant disease, more red men on the left column compared to the right column. But in the left-hand column, nobody avoids a biopsy. Whereas in the European method, the blue men are the people who avoid a biopsy, and the yellow men are those men with insignificant cancers. So you can see there are more men with insignificant cancers in the North American method compared to the European method. So you can see how the risks and the benefits can be altered depending on the pathway that you use. The final thing you can do is you can adapt the histological evaluation of the samples according to the way the biopsies were obtained. Now, all of us know that MRI conspicuity is directly dependent on the Gleason score. In other words, the lesion that's most conspicuous on the MRI is likely to have the highest Gleason score. There is this inverse relationship between the ADC value and the Gleason score. So what we end up doing by doing targeted biopsies is we get a risk inflation, because we only biopsy the lesion with the highest conspicuity or highest Gleason score, and we underestimate the rest of the tumor which we can't see. And this is called the Will-Rogers effect. In fact, a number of investigators are altering the definition of clinical significance depending on which core found the highest Gleason score. And I've given you some examples of some authors that have done that recently. In fact, the ISUP, the International Society of Uropathology, is recommending that pathologists don't report the highest Gleason pattern in the targeted cores. Instead, they suggest that all the targeted cores are aggregated, and the highest percentage of Gleason 4 pattern is reported, as you can see on the left-hand side, to try to mitigate this Will-Rogers effect. So here are my 5 golden rules for balancing the benefits and the risk of MRI pathways. Number 1, make sure you risk stratify patients before the MRI and adjust what is positive and what is negative on the likely prevalence of important cancers. Remember, you need to account for the patient's tolerance to either false reassurance or false alarms. Remember that a biopsy after a negative MRI is generally unjustified unless there are clinical risk factors which say you should biopsy. Instead, think about using safety net protocols. Adjust the MRI suspicion score for biopsy decisions using PSA-density or a calibrated risk calculator. remember to optimize the biopsy method and the histological evaluation of the biopsy cause, particularly when you perform targeted biopsies. Thank you very much for listening. I hope you found these comments useful for your clinical practice.